Okay, guys, we're going to go into the assessment of our respiratory system. This is going to be a review as well, kind of focusing on some more paramedic level assessments when it comes to actually evaluating your patient. As soon as you guys make patient contact, all the way during reassessment while you guys are actually treating the patient or waiting to give turnover report in the hospital. Okay, so when we're talking about the actual assessment, this starts as soon as we make eye contact or at least see our patient when we are approaching on scene or we're approaching our patient in the first place. Just like in basic class, right? We want to do ABCs. We want to evaluate the actual AVPU of our patient. Okay, we want to make sure that we can get a good start of an understanding of what their LOC might be, even though this is the first time that we're actually meeting them. So when we're talking about LOC, we want to see if our patient's actually tracking us as we're approaching. Okay, are they tracking us? Or are they not tracking us? What do they appear like? Do they look cool, calm, collected? Do they look irritable? Are they agitated? Are they trying to find that position of comfort? Do we see any signs and symptoms of shortness of breath? Right? Can we see that they are their work of breathing is up? Are they tripoding? Do they look pale? Are they sweaty? Right? Stuff like that. In order to really do a good, thorough assessment. Okay. We're also looking to see if there's any equipment. Right? If they're actually on any equipment, are they wearing oxygen normally? Is the oxygen turned on? Is the oxygen plugged in? Are there no kinks in the actual airway line? Most of the times, and you guys know this, that when we arrive on scene with somebody that is actually wearing oxygen, usually there's about 40 feet of tubing when the actual regulator itself is at 2 liters. They are definitely not getting 2 liters of oxygen with that 40 feet of tubing, but we do want to make sure that it is turned on at first, make sure that they are compliant with actually wearing their nasal cannula when they're supposed to be, and make sure that there's no kinks in the line. Kind of start from there. Okay, so airway and breathing is what we're focusing on with respiratory. You guys will get circulation and cardiac. Okay, so when we're talking about airway, is it patent? Is it open? Right? Are we noticing them drooling? Do we see angioedema? Do we see they're spitting out blood? Do we smell emesis? Possibly there could be some kind of aspiration, depending on how our patient is positioning when we find them. All right. How easy is that to fix? Okay, can we fix it with just a head tilt chin lift? Can we actually fix that airway by actually just sitting our patient up more if they're laying down? Do we need to do a jaw thrust maneuver if this is trauma? Do I need a simple adjunct? Do I need to go to a NPA or OPA in order to establish my airway? And always in the back of your mind, you should be putting suction in there as well. Breathing, on the other hand, right? When we're evaluating breathing, we want to see if our patient is actually able to speak. And if they are able to speak, are they speaking in full sentences, or does it take them a little bit to catch a breath in between the actual words that they're speaking? And also, when they are speaking, is it making sense, right? Are we seeing accessory muscle use? Do we see them using their neck muscles, straining out their neck, cervical plexus muscles, right? Can we see the intercostals actually being sunken in the rib cage? Do we notice belly breathing? Are they trying to find a position of comfort? Are they already in the tripod position to begin with, right? Positioning, just like I said, if that patient's laying down, they're complaining of shortness of breath, let's prop them up, right? Let's get them sitting up if they're able to by themselves. If not, let's prop them up with some blankets. At the very least, I would even just try to get them in the actual stiffing position right away, even while you guys are asking them questions in order to help them catch their breath. And then, do we hear any audible sounds, right? Does it sound like their chest rattles when they talk, or can we hear the wheezing, right? Do we hear stridor? But again, with breathing, make sure that we're listening to lung sounds, making sure that we are doing respiratory rate, depth, and effort. Okay. When we're talking when we're listening with the primary assessment, we want to listen any anything that the patient says as far as chest pain. Okay, we're going to kind of start doing the whole differential between is this cardiac and is this respiratory, or cardiac versus respiratory chest pain. Do they have a respiratory complaint? Okay, that's a big one. Are they complaining of shortness of breath, breathing 26 times a minute, or are they complaining of shortness of breath, breathing 40 times a minute, right? Or are they sitting there and they're actually talking to you, but for whatever reason, they're real pale and looks like they're just hypoxic. They don't look like they're really perfusing that well, right? Those are all signs of what might be going on with the patient. Any trauma or any recent trauma, okay, let's go back at least, let's say, a week, maybe even a month, depending on our suspicions of what might actually be happening to the patient. And any recent neck trauma as well. All right. And breath sounds. You guys have practiced breath sounds. Most of you guys are working in the field. We want front, back, and flanks, guys. Okay, front, back, and flanks. You want to try to get a good full set of breath sounds. Some people prefer the back, the posterior side compared to the anterior side. Just make sure that you guys are actually listening to the full set of lung sounds, so that you guys do not miss anything. Okay, so as we're checking out our patient and we've cleared the A's and B's, we want to make sure that we are actually going to start looking at the airway as well. Looking specifically, even evaluating the moisture and mucosa of the mouth, right? Looking in the airway while your patient is still awake, right, kind of gives you a couple advantages. You can see the melon potty right off the bat, just in case that this patient does crash, and see if there are any deformities that you might have to work with if the patient has dentures or not, right? If you guys can actually see any swelling, you might see blood in the back of the area of the airway that you might have to take care of before you guys actually. If you guys are going down that route of intubation, you might have to take care of, or something that you might even have to take care of before you even continue with your patient assessment. Alright, so we are inspecting for angioedema, right, when we're looking in the upper airway, and we're trying to really kind of visualize that posterior oral pharynx, or gaining the melon potty, however you want to put it. Remember the class 1, class 2, class 3, class 4 melon potties from our lectures previously. Make sure you guys go back over those and you guys understand those. Okay, that class 1, we can see we can fully see the soft palate, we can fully see the uvula, we could even see the pillars of their tonsils, right, if they still have their tonsils. But really we're looking for any kind of swelling that could really hinder us when we go to intubate. We're also looking for foreign body airway obstructions if this patient is unresponsive, and we're also looking at the mucosa linings to see if they are dehydrated, if they happen to be dried out, or if they look like they are taking care of their teeth, right? Dental hygiene, making sure that they don't have dentures or anything like that. Okay. When we're talking about angioedema, all that means is blood swelling. Angio means blood vessel, and edema means swelling. Okay. That's not a good sign. That's a scary looking tongue right there, right? Definitely don't want to see that. But as you can see in the picture on the left, we have some very large tonsils that we may have to deal with when it comes to intubating our patients. Okay, so when we're evaluating the actual need for intubation, remember we're doing our lemon mnemonic. We are going to be looking externally, and again, I'm not going to spend too much time on this, but we're going to be looking externally in order to see if we are going to be having a difficult airway right off the bat. We're going to evaluate the 3-3-2 rule. Remember, that's three fingers in the mouth to check to see for mobility, 3 fingers along the bottom of the chin to see how much actual room we have to play with, and then the 2 fingers kind of showing the actual back of the throat to see the depth of the actual throat when we're actually going in there to intubate. Melon potty we've already talked about. You guys can look that back over on your notes. Obstructions, we're looking for those obstructions, right? Drooling, blood, teeth, dentures, Legos, right? angioedema, lacerations to the tongue, any kind of trauma involved in the mouth can also cause an obstruction. But you guys know as well as I do, anything can be obstructing the actual airway. And then we want to make sure that we have good, adequate neck mobility as best as possible, right? If we do have to C-collar our patient, then we have to C-collar our patient. We're going to have to work around that C-collar and keep that in the back of our mind. If we do have to intubate that, we are not going to have a lot of play when we actually try to pull up for getting a good look into the airway. Another look at your Mellon-Potty scores. We're hoping for a score of 1. Okay, you guys can see the actual pillars of the back of the oropharynx. You guys can see the soft palate, and you guys can see 100% of the uvula, and you do have a decent size opening between the uvula and the tongue itself, and the base of the tongue. Mellon-Potty score number 2. You can still see the pillars. That hole is getting a little tighter. You could still see the uvula, or at least the majority of the uvula. We're still considered in the class 2. When we move down to the class 3, you guys can see that all we're starting to see is just the soft palate and the very top of the uvula. The uvula is no longer viewed 100% or even 50%. It's a little bit more than that. And then a Mellon-Potty of 4, all we can see is tongue and soft palate. And that is a terrible airway. I hope you guys never see that, but if you do, remember that this is also corresponds with the Cormack and LaHave grading scale, right? So the grade 1, grade 2, grade 3, grade 4. If we show a Mellon-Potty class 1, more than likely we have the grade 1 Cormack and LaHave grading, which means that we can have full view of the vocal cords. It's going to look very good once we get that laryngoscope down there and taking a look. Where if we're already starting off with the class 4 Mellon-Potty, we're looking at a grade 3 or grade 4, which is going to be a terrible view of the vocal cords, but we knew that going in because of the way we already saw our Mellon-Potty. Okay. Slide showing the correlation between the actual Mellon-Potty classes and the Cormack and LaHave grading scales. All right, you can see a class 1 Mellon-Potty compared to a grade 1 Cormack and LaHave compared to a class 4 and a grade 4. All right, so you guys can look those over, as I'm not going to go much into that anymore. All right, when we're dealing with the next exam, we're kind of looking at left and right for symmetry. Okay, using the trachea as a midline, right? We're going to look at the right and left side of the neck, see if there's any swelling. This is where you guys could potentially start seeing like some sub-Q emphysema. If we have some kind of tracheal injury, right? If we have a hole in our trachea, if we're actually leaking air from our trachea, right, as this patient is breathing in and out, we could start seeing the actual development of the subcutaneous emphysema. It's usually kind of noticeable right by the collarbone, right? It's going to be like this little pocket of air. When you guys feel it, feels like Rice Krispie treats, kind of like a hacky sack, right? If you're to put like a well, let's put it this way. Let's say if you put like Rice Krispies in like a Ziploc bag almost, right? And you kind of start playing with it a little bit. That's what it kind of feels like underneath the skin. We want to make sure that the trachea is midline. Okay, make sure that the trachea is midline compared to the right and left of the musculature of the neck. We want to look for JVD. That's that jugular vein distension. Again, that is some signs and symptoms of some of the disease patterns that we're going to talk about later on in this course. Check out the thyroid gland, right? Kind of palpate around the larynx and the actual voice box around the trachea. All right, and make sure that all the anatomical structures feels like they're in the places that they're supposed to be, and there's no kind of deformities that you guys know. And then definitely listen for stridor. Put your stethoscope right on that trachea, right, and just listen to that patient breathe. Okay, and see if we can actually hear mild stridor in that upper airway. You can also, if the patient is not trauma, right? If we're not dealing with a trauma patient, let's try to kind of manipulate the neck a little bit. Let's see if they can turn their head from right to left and up and down without any pain or without any struggles. Okay, so when we're talking about the lower airway and the chest area, we do still want to inspect it even if we are not suspecting any signs of trauma. Okay, we want to look at the skin. We want to look at the skin around it. We want to see if there's possibly maybe some accessory muscle use that we couldn't see with them wearing their shirt. All right, so always try to expose the chest if your patient's comfortable with it and you really feel the need that you need to do it. Make sure that you guys are exposing it. When we're talking about the actual shape of the chest, when we talk about barrel chest, this should be a kind of review from basic. Whenever we're talking about that barrel chest, remember it is as wide as it is thick. Okay, so it looks like a barrel. Those are usually with our emphysema patients, our lungers, right? They're going to just exhibit the barrel chest. The other two are rare, but we do need to talk about them because they can. They're not that common, but they can pose a kind of some issues when it comes to other things as far as treatment. All right, when we're talking about pigeon chest, which is the actual picture that you guys are seeing in the upper area of that slide, pigeon chest is actually caused by a couple different reasons. Mostly it's genetic, or it can be also associated with another type of disorder. It can be associated with open heart or growing males that are growing through puberty. Okay, can actually develop a pigeon chest. If they are born with it, it usually rounds right about age 3, and it's also associated with a number of different syndromes. All right, I'm not going to test you guys on this. I just want you guys to kind of see this, so it's not a surprise if you do see this, and just kind of give you guys some basic explanations. Okay, when we're talking about the funnel chest, which is the one on the bottom there, this is actually caused. It's really not understood too well in the medical community on how this is caused. Researchers believe that the actual deformity is caused by an excessive growth of connective tissue, or just basically cartilage that joins the ribs to the breastbone. And from my understanding, this isn't permanent, but both of these obviously will kind of put a little bit of a hinder on how we're actually doing CPR on the patients. Obviously, we are still going to do CPR on the patient. If we need to do CPR, these just might be a couple complications that we actually have to deal with when we actually look and have to visualize the chest.